Welcome, everyone, to the Community Technical Assistance Center of New York. We have an exciting webinar today. Today's webinar is called Addressing the Mental Health Needs of Children with Incarcerated Parents. And we have Anna Morgan-Moline from Children of Promise with us. But before we get started, I just wanted to do a little bit of housekeeping. In particular, I think in the announcements, everybody saw that this webinar is 1CE eligible for licensed social workers and mental health counselors. We will be providing you with information on how to access the CE at the end of today's webinar. You'll also receive that in an email after the webinar, probably within the next day or so. I also wanted to let everybody know that this webinar is being recorded. The slide deck and handouts will be posted on our website at ctechny.org, and we'll announce that again at the end. But, you know, no worries, because everything will get posted on the website. It'll probably take a day or two for everything to get up on the site if you're interested in accessing that soon. All participants are muted, and what we would like you to do if you want to communicate with us is to use the chat box. The chat box is on the bottom right. If for some reason you don't see the chat box, there's a little chat icon on the top right that you can click, and that should open up that chat box. We encourage strongly for you to provide feedback, to make questions and comments. Just make sure that when you type in your question, in the drop-down just above, you click Send to All Panelists. That way we can all see your questions or comments. If possible, the presenter may answer one or two questions during the presentation. We also may decide to just hold them till the end Q&A period. There will be time at the end of the webinar to address any questions that you may have. Also, at the end of the webinar, when you close out, there will be a feedback survey that pops up. We do highly encourage you to complete that as we do look at that to help inform future offerings. So without further ado, we have a wonderful presentation by Dr. Anna Morgan-Moline. She's the Vice President of Mental Health Services for Children of Promise in New York City. Working in partnership with her founder and president, they developed Article 31 mental health clinic that serves children and adolescents impacted by parental incarceration. That's the primary focus of the mental health clinic. And Dr. Morgan-Moline also spends quite a bit of time developing clinical policies and practice guidelines and developing evidence-based treatment models that help to address the specific challenges that children of incarcerated parents have. So without further ado, I will pass it over to Dr. Morgan-Moline to kind of get us started. Thank you for joining us.
Great, thank you so much. Welcome everybody, good afternoon. I'm very honored to be able to provide all of you with an overview of the work that we do in New York City and Bedford-Stuyvesant, Brooklyn. The sort of purpose and the goals and objectives of today's training will be to understand mass incarceration first through a historical and current context, to then discuss a little bit more about my agency and the clinical practice that we provide at Children of Promise. We will then discuss parental incarceration as the primary trauma, which we've been able to do through our 10 years of research and narrative work with the children and families we serve, and how we've been able to utilize modifications and adaptations to specific theories and interventions that guide our clinicians' practice with these families, as well as our usage of trauma-centered care, which is grounded in critical consciousness and cultural humility, and our recent research and practice around dismantling anti-Blackness practice with this population as we take a closer look at mass incarceration, and how practitioners can really start to understand the relationship of our clinical education and practice in the mass incarceration era with children of incarcerated parents. So if you have questions throughout, one of the I would be very interested to know if any of you are currently working with children who have one or more parents in prison or in jail, and if you do, if there are common questions or challenges that you might experience, I would be more than happy to answer them either, throughout the presentation or at the end. And you will also have my contact information at the end, so you can feel free to continue to follow up with questions. I'm more than happy to stay connected to agencies that are serving this population. So to get started, I'd like to, really have a discussion quickly around the implications for, practitioner work and education and clinical practice. My area of focus is social work. However, we do provide a learning opportunity for several different providers who are working with children and adolescents impacted by mass incarceration. So we know that this is especially important for anyone working with justice-involved individuals. The why criminal justice is so relevant to all of our practice is because of the numbers, predominantly. As you can see here, currently there's 6.7 million adults that are under some form of correctional supervision. There's more than 2 million juveniles who are arrested on a yearly basis in the United States. 11 million people are cycling in and out of jail every year, and what this means is that it's actually a growing number now, but over 2.7 million children have one or both parents in prison in the United States. And what does this mean in terms of these disadvantages? So a lot of this is associated, these disadvantages listed below in our research are really associated with criminal justice involvement and the family level or individual level that needs to be properly addressed by service providers who are working in areas where there's implications for poverty, substance abuse, mental illness, and poor health care. So understanding mass incarceration, I'm sure that this is a phenomenon that hopefully everybody is very familiar with, but Michelle Alexander really says it best when she says that it's a system that locks people not only behind actual bars and actual prisons, but also behind virtual bars and virtual walls. Walls that are invisible to the naked eye but function nearly as effectively as Jim Crow laws once did at locking people of color into permanent second-class citizenship. And what we have to understand as practitioners and providers in these settings is that, the leading causes of mass incarceration include discriminatory ideologies and policies that were developed, as we know, to the, response in the war on drugs and the war on poverty in the 1960s and 1970s. And in the early 1990s, actually, is when the harsh sentencing laws, such as the three strikes law, mandatory minimum sentencing, et cetera, became very impactful to several of the communities that many of us, I imagine, are probably serving. So it's very important to have that recognition as a provider when being able to go into these spaces, that it's not just also about the current separation that children and adolescents have with their loved ones, but also all of the stressors and factors that are facing these parents when they're returning home. I also like to teach, I teach at NYU, I teach a policy course at NYU, and I think it's really critical as clinicians that we also carry the knowledge that, as incarceration rates were going up, violent crimes were actually declining, which suggests that incarceration rates are driven by nonviolent crimes. Later I'll discuss, the stigma and shame that's often associated with the children who experience, opening up and sharing about their parents being in prison, because the myth is that it's usually something that's, related to violence or related to drugs, which is not the case. So having an awareness too, again, that more than 60% of people in prison are people of color. So again, really having a recognition to the communities, that all practitioners might be serving, having this level of awareness that these are disproportionate rates of incarceration. And so the likelihood of people of color being incarcerated versus those who are, Caucasian, I think is really important to hold as service providers, that at any point you can see from this particular chart, African American men and women are at the greatest statistical risk of incarceration. Because of these statistics and numbers, and these growing rates of communities that are most impacted, 10 years ago, my CEO, Ms. Sharon Content, really saw a call to action to be able to develop an agency that's grounded in the principles of community psychiatry. And she developed the first ever after-school mentoring program, tutoring, summer camp, and eventually the Article 31 that she and I established that's specific for children of incarcerated parents. A lot of the research that really fueled these practices and these particular therapeutic programs, show that without some sort of effective mental health and academic intervention, the 2.7 million children a growing number, will be 70% more likely than children who do not have a parent incarcerated to have some level of criminal justice involvement in their lifetime. And again, this is not, I want to be clear that this is not a behaviorally based, outcome. This is really looking at the systems that are the most disruptive to many of the children and adolescents that were the same systems that were, disrupting any opportunities for their parents. So the numbers behind the need, once again, just to reiterate, I think numbers are very important across the country. Like I said, 2.7 million children have one or more parents incarcerated, and many of the statistics show that these parents are serving anywhere from 5, 10, 15 to 25-year sentences. In New York City alone, there's 105,000 children who under the age of 18 that have one or both parents in prison. So as you can see, it's a growing population that are rarely targeted for interventionary services that as they have unique needs, which I'll go into in a moment. With this growing number, there have not been unique opportunities for them to be able to experience particular interventions that are tailored to their psychological and traumatic experiences. The services that we offer within our agency, as I mentioned, are, we service children 5 to 18 years old. We say 17, but many of our children that turn into adolescents and young adults actually then join an internship and employment program. But we are a nonprofit located in Bedford-Stuyvesant, Brooklyn. We have secured our second site for the South Bronx that we will be opening up next year, and actually hopefully in Brownsville as well. We are the very first Article 31 outpatient behavioral health clinic specifically designed for children and adolescents whose parents are incarcerated. And the services we offer are clinical services. We do a lot of mitigation work, case management, mentoring, psychiatric, academic interventions, and then we are co-located within our after-school and summer programming. So our mental health services are offered on-site during the after-school and summer camp hours as an opportunity to really destigmatize the face of mental health for many of the families who have shared with us over the last 10 years, that they felt very ambivalent about seeking services in other facilities because there was such a very much a deficit perspective and a social stigma that was attached to the implication for that parent who was in prison. So being able to really utilize a strengths perspective and starting with a healing-centered, I would say, lens, essentially, in partnership with the social workers and practitioners and psychiatrists working with this population, just the environment alone was much more comfortable for a lot of the families because they felt like they were getting services in this space that they were already so familiar with. So what we know about the collateral consequences of incarceration is that we are seeing more rates of mothers who are becoming incarcerated. So 75% of incarcerated women were the primary caretakers of at least one or more of the children prior to their incarceration. So this has led, obviously, not only to specific instability and risk of financial and residential instability, but a lot of the parents and caregivers have reported higher rates of traumatic effects, such as insecure attachment related to depression, anxiety, and trauma-related stress, which we'll get into in a moment. But just understanding, again, upon assessment and acknowledgement of what these particular stressors are, these we were finding to be the most important to acknowledge. So not just the financial instability, but the growing rates of psychological and traumatic symptoms related to that instability. In our particular program, we were also finding during enrollment services, it was revealed and shared to us that several of our children, participating in all of our services were born in prison. So a growing number of the children were sharing that they experienced some of the first years of their relationship with their parent through visitation. And this reinforced, again, a deeper look at what the psychological and traumatic experiences were of those children who were separated immediately at birth or after a few months from their caregiver, and then trying to develop an attachment to that caregiver through visitation. So all of this is what really did lead to our particular tailored and adapted interventions that we employ at the agency. All of our feedback and research has really come directly from the reported experiences of the children. What our children were reporting, having higher rates of mood instability, feelings of anxiousness, disassociation. Several of our adolescents would describe, I share about this later, but, having witnessed the arrest of their parent, really presenting with symptoms that are similar to that of more of a traditional diagnosis of PTSD. But, these trauma-related stressors were showing up in ways where the students would talk about getting into fights, getting into arguments, feeling triggered, and going into a blackout. And, what we were recognizing is that disassociation, was something that, this disconnect from their own body, really understanding that when they were coming to with a lot of these fights and arguments, that there was so much of this psychological kind of space that they couldn't really account for. And, obviously having a more challenging time to adjust, because there was this, for all of our children, these arrests, again, that they witnessed were very abrupt and very intrusive and terrifying. Our adolescents also report substance use, and they have a lot of disruptions in eating and sleeping. There was a young lady who shared that, she was getting in trouble at school for not eating her lunch during lunchtime. She was a 6-year-old, and she was about to have, specific ramifications for that. And what ended up happening was, during our particular assessments and interventions and relationship to to going into the school and really advocating for what was happening with her, she revealed to her teachers that her father, who was in prison, his prison was on a hunger strike. And so because he was doing that, she then wanted to do that to feel like she could be closer with him. So again, a lot of the children in our program and parents in the program will come with many misdiagnoses, many sort of misinformed, labels and symptoms that are sort of being placed on them that are not allowing for the recognition of the impact that this incarceration does in fact have on them. Several of the children as well, one of the reasons why we offer such extensive academic support on site is because many of our children experience grade retention at higher rates. There's a lot of behavioral concerns that the teachers will call the agency regarding, when in fact, the adolescents and, young children are performing at grade level, but because of these barriers to the behavioral challenges faced at school, many of them are getting held back. I think that this particular statistic is really important to have an understanding. So what does the intergenerational cycles of justice involvement mean? According to the U.S. Department of Justice, 70% of children who experience familial incarceration will enter into the criminal justice system. I want to be very clear that, again, I can't stress this enough, this has nothing to do with behavioral attributes, this has nothing to do with personality. Many of our children have faced a lot of stigmatizing statements like, you're from authoritative figures saying that, that you act just like your mother or you're acting just like your father. But what we understand this percentage to mean is that, again, they are facing the same experiences of systemic racism and oppression that their parents experience, and there's a lack of support, involvement, and encouragement along the way to really honor this intergenerational trauma. And so that's what's led to this 70%, is these same lack of resources that are not afforded to the parents are not being afforded to the children. The guiding theories that we use within the agency that then kind of trickle down into our individualized clinical practice is this idea of conspiracy of silence and ambiguous loss. What the conspiracy of silence is many of the caregivers have upon first meeting them, when they first started with the agency about 10 years ago, they might choose to entirely or partially withhold information regarding parental incarceration from their children, as they assume it would be a helpful coping strategy, or instruct the children not to talk about it even if the child is aware of this. However, this deliberate information, either toward children or towards outside society, it's been referred to as a forced silence. So this has been part of the reason that we've seen we talk about this. The children impacted by parental incarceration as being an invisible population to the criminal justice and child welfare systems, is there's this idea that they should not be speaking about this. And what we found was that, when many of the children first started our program, they talked a lot about this idea that they weren't supposed to talk about it because they would be judged for it, or their parent would be, spoken about badly, or, everyone would be criticizing, who their parent was. And we at our agency honor that despite the infraction, we hold true that this is their parent first and foremost, so we honor that relationship, and we've tried to infuse all of these practices and therapeutic exercises that they get to do throughout the agency as an opportunity to speak freely about this loss in a way that will be non-stigmatizing. And what we were finding in terms of, the relationship to ambiguous loss is, the most stressful kinds of loss can be ambiguous. And so as they persist with uncertainty, our children would often disclose, what we recognize as sort of a blocked cognition and a stunted grieving process that was not allowing for very much closure, because they were being told that your mother or father is away at school or at army camp or at the hospital. There was not an opportunity to have this kind of grounded, concrete understanding as to, well, then why can't I see my parent? So because of this, we were finding that many of them were coming to incorrect, distressing conclusions about their parents' absence, that it was either voluntary, that they themselves were the ones to blame. There were several, 5 or 6 year olds prior to understanding that their parent was incarcerated, and kind of what was happening is they thought that maybe their parent went away because they were doing so badly in school or because they were getting so many calls home. And so they're trying to really find some understanding of being able to make sense of something that, needs to be sort of more concrete for them. We were finding that more children were becoming withdrawn and distrustful of their other caregiver, and, this was impacting their inability to have attachments, positive attachments. So we really tried to work with this ambiguity and lift this conspiracy of silence to help unfreeze this grieving process and be able to really support a level of healing that would be non-stigmatizing. So examples of this, from the participants in the program, this is what, the conspiracy of silence and ambiguity looks like from the voice of the children. This is one of our participants who shared, all of my friends say, I want to see your mom, and my grandma says I can't tell them she's in jail. She would be furious because if I told everybody, it will be out of the bubble. Then everybody would be talking about it, and I'd get sad, and ACS would take me away. It scared me a lot to have my mommy in jail. So for this particular participant who shared this, what she has been expressing over the years is that there was so much confusion. There was so much sort of misunderstanding, but what she did know was there was a lot of, threat that would also come. Many of the parents, or children who witnessed the arrest of their parents, ACS was immediately involved. This was, identified as neglect and being an unsafe, sort of home, which we've helped to really unpack and undo and recognize that, a lot of the systems don't always respond in the ways that can be the most supportive of the child and even of that parent, and allowing for some of these questions to be answered and allowing for the feelings to be felt with a real healing opportunity to, for this particular child. And she really was able to have some of her concrete questions answered and then be able to feel safe to talk about how much she missed her mother without fear that there would be consequences for her and her family. Another example of silence and ambiguity is one of our participants talked about, at first when I knew that my dad was in jail, I cried. Then I thought maybe he'll come home today, but he didn't, so then I cried some more. I felt like Daddy would never come back, so I felt mad and sad at the same time. But actually, one day he will. But sometimes I think, did Daddy leave you on purpose? I was worried and confused then. So again, just kind of feeling like prior to starting our program, this particular participant shared that, he too felt like there was, this was something he couldn't be speaking about. He couldn't make total sense of it, and experiencing a lot of confusion and worry really resulted in later larger feelings of anxiety. So being able to really tackle this at the root and, have an open, expressive space for him to be able to process. Additional guiding theories that we utilize when really looking at this from a lens of historical trauma is we train our staff in historical trauma theory, and this is really important to be able to understand in terms of life courses of populations that are exposed to trauma, looking at legacies of trauma that are passed down through generations, looking at multiple losses over time, and again, how does this relate to symptomatic stressors that should be associated with those losses versus with traditional forms of, many of our children and parents would say that they were given ADHD diagnoses or ODD diagnoses or things like that in other settings that gives no account to these traumatic losses over time. And, community-based practices must address historical trauma as it relates to structural oppression. That's our belief. We bring in discussions around mass incarceration into all of our clinical practices. So in our clinical practices, I'm going to speak a bit now about the psychotherapeutic theories and interventions in our clinic, and we call it a wellness center, after-school program, and other community-based practice settings that we've gone and trained in. We've taken elements of trauma-focused cognitive behavioral therapy, narrative therapy, and relational therapy to be some of our primary therapeutic interventions as a response directly to the experiences and narratives of the children and adolescents. So I just want to briefly touch upon, again, really trying to identify parental incarceration as a primary trauma. This is something, when you think about ACE's study and how there was, many of our children will say things like, society will honor and respect, a child who's lost a parent to the war, or who's going through an experience where their parent is going through a divorce, but like, where is there room for me to talk about my parent who's in prison? And so in doing so, this is really why we've tried to push in our research this notion that parental incarceration is in fact a primary trauma. And so this slide is just sort of a reminder that many of our children are in fact going through a lot of these experiences. And one thing that I want to point out in particular, that, trauma teaches children that the world is dangerous and adults may not be able to protect them. There's complex traumas as it relates to, these systems significantly related to mass incarceration, such as over-policing and over-discrimination utilized in a lot of the neighborhoods that the children are living in day to day that reinforce a lot of fear. They've witnessed their parent be arrested. They've witnessed a lot of brutal, many of them have shared how violent a lot of the arrests were, and then to have these trauma reminders kind of throughout their community really perpetuates a lot of the symptoms of trauma that they experience on a daily basis. So what this chart here sort of is a brief overview of is really how we try to bring in all of these practices in our clinical work. So our therapeutic interventions and theories that we apply reinforce the therapeutic bond, not just with obviously the clinician and the child, but really just having the clinician join the family and be able to really sort of strengthen a lot of the bonds with a lot of the family members. Understanding that the quality of the working relationship is what drives the therapeutic relationship. So we propose that these therapies, when practiced with critical consciousness, lend themselves to the establishment of strong therapeutic relationship, which allows for the healing process to ensue. So practitioners can broadly use attachment theory and trauma theory, as well as therapeutic interventions, including, what we've kind of now titled trauma-centered CBT, narrative therapy and relational therapy for assessment and treatment of the psychosocial stressors that a lot of the children face. And what we do is we interpret, initial sort of interviews and develop a person-centered, social history as a part of the context of attachment when planning interventions, and organizing these appropriate pathways to correct negative feelings about self and object working models toward the objectives, and adopting more of a secure attachment style, and more so a meaningful personal narrative and healthy coping strategies. So this is all centered around, all of our practices are really centered around the clinician cultivating the self-awareness as to who they are in this relationship with children and adolescents who feel very misunderstood by broader society because they feel their parents have been criminalized and really dehumanized by society. A really important point to highlight too is this idea of secondary incarceration. Many of our children will talk about, psychosocial, issues that really do stem from this idea that, it's very common on a day-to-day basis. You could hear a student say, they call me Miss A at the agency, and they could say, Miss A, my father might be doing 10 years in prison, but I'm doing 10 years on the outside. So this notion that, the person who is in fact incarcerated is, is having this really horrific experience, but I too, as their daughter or their son or their child, am going through my own kind of incarceration while they're away as well. And again, just reiterating, like, from this idea of what secondary incarceration means to our participants, shows up in, again, these stressors and these behavioral challenges or academic challenges, and feeling of just inability to sort of cope with mood. The how we utilize our treatment plans and developing sort of treatment with the family is really stems from, using culturally appropriate and assessment tools to identify what the trauma symptoms are and how does the child and parent really want to move forward, and letting them, again, utilizing critical consciousness, having an understanding that we are not in the driver's seat, that the child and the adolescent and the caregiver are really the ones that should be driving the treatment. We've adopted and developed culturally responsive tools, assessment tools, that we feel have been the most helpful. So this is the trauma symptoms checklist for the parent and child, which is one that we use at the time of intake. We use the trauma history questionnaire. We use the child PTSD symptom scale. We use the strengths and difficulties questionnaire. And we utilize a cultural formulation interview and questionnaire. And why we use this is because, again, many of our children have reported feeling like when they've received treatment elsewhere, it's come from this like deficits perspective. So in order for us to really use culturally responsive assessment tools to then help us to develop goals and objectives, we feel like a lot of these particular tools have a positive impact on, healing and recovery, and I allow for there to be more clinical discussions around strengths and areas that even that the child wants to address. And there's an opportunity during intake on how they themselves view their own challenges and reinforce the strengths of their cultural background and the strengths within the community and sources of support or religious or spiritual practices that we then as practitioners get to really partner with. And again, just to kind of, reiterate more theories that we hold very tightly to is attachment theory. I'm sure many of you are very familiar with attachment theory and trauma theory. But why we, again, I just want to, reiterate that because attachment theory has to do with the level of trust and support in the relationship between a child and caregiver, the quality of the attachment expressed through secure, anxious, and insecure and ambivalent behaviors is oftentimes overlooked. And again, there have been countless instances where, we've served over probably 1,000 families, and 80% of them have said, that they've come in with, being told that they're bad and that something's wrong with them, and that, there's no psychoeducation around trauma and around sort of what their unique experience is. So being able to have an understanding and honoring that, with this disruption in this attachment, with this primary caregiver that is incredibly meaningful to this child or adolescent, without utilizing that as our clinical, lens, then we are completely missing an opportunity to understand the critical changes that could be taking place if we were to be a lot more inclusive around the loss of this parent, and honoring, that all, traumatic experiences, as it states here, impact the entire person. Thinking, learning, memory, self-conception, views of others, and how can you use a safe therapeutic relationship not to replace the person who is incarcerated, but to help lend an opportunity of safety and restructuring of a belief that more attachments can be built with other supportive and therapeutic people in the lives of each child. So I'll briefly, just reiterate that, again, the relational therapeutic part, I just want to highlight again, because we've seen a lot of these relationships, the clinicians will really join the family and really be able to kind of recognize that their role is just to really be a channel and to be a vessel for change that already exists within each child and adolescent. And through the narrative, which I'll get into in a moment, through the opportunities for the individual to share their own narrative and to see their own power, this is how we use these theories, and this is how we bring about healing and change that also is very inclusive, which I'll share about in a moment, but it's very inclusive of that relationship to the incarcerated parent. What I forgot to mention in the very beginning is a huge piece of our program is also a continued connection to the incarcerated parent. So we have buses that go up to each prison where the child's parent is to ensure that they're able to do weekend visits with them. We have a letter writing program where the children are writing letters on a weekly basis to their parent who's incarcerated. And starting in September, we're going to have televisitation opportunities where the children will be able to, for those particular settings that have televisitation, our children will be able to interact with their parents over some form of Skyping. And this is because, again, we recognize that we need to support a secure attachment that can continue to grow even with this physical distance, having this emotional attachment continue to be strengthened through the work. As I mentioned before, I'm sure many of you are very familiar with, trauma-focused cognitive behavioral therapy. We've utilized a lot of adaptations and modifications to this particular model, but why we like this one so much as a clinical tool is because it starts first with psychoeducation. So the information and validation and normalization of what a child is experiencing during this time of loss, as well as ongoing feelings of a lot of pain, a lot of depressive symptoms, symptoms related to anger and aggression because of this rage that they can't see their parents. This has permitted an opportunity for the family to really have an open discussion about how normal many of the behaviors are that originally are that are being viewed in other places as incredibly problematic. The relief that I have seen countless parents have when we've talked about how what their child is displaying is absolutely accurate for what they've just gone through has been, the endpoint of a healing opportunity. So being able to first really talk about what trauma is and like what this separation looks like in the behavior of the child is why this is a particular model that we like so much. And then moving into the coping strategies, many of the children and adolescents have reported loving a lot of the different cognitive tools, relaxation. We really use strategies that focus on breathing, progressive muscle relaxation, and visualization. And recognizing there's a level of empowerment that we've seen happen with the young children and adolescents who really appreciate learning about their own thoughts, feelings, and behaviors, and being able to replace a lot of these negative cognitions and distorted cognitions that are related to a lot of their day-to-day events or this loss with more helpful cognitions that they themselves create. It gives them an opportunity to feel very involved in their own process. And then as we know, affect regulations, this is a lot of like the strategies that our adolescents really appreciate using, which is positive distractions sometimes, being able to utilize journaling or art, mindfulness. These types of practices are offered both on-site within the agency. We have art therapy, we have group therapy, we have specialized, sort of more trauma-centered, activities and exercises. And then how do they take this into the real world and feel like this is something that becomes a part of their own opportunity, to be able to have more control over the times when they feel, as our younger children will say, when the times that they feel like their behavior is just is out of control in their own language. And then what we appreciate also about this model is the trauma narrative and the enhancing of safety. Again, understanding that our role is just meant to really be a vessel in this therapeutic process. The power of the family and the unity and the healing of the family is what's most important. So the writing of the narrative has been some of the most powerful and impactful moments that I've been able to clinically witness in the last 10 years with the children who then get an opportunity to read this experience to their parents, who had a very different experience of this separation and loss of this loved one, and feeling like there is room to be able to ask all the questions, to be able to feel like all of the feelings get to be expressed, everything gets to be shared without there being fear of getting into trouble, having a consequence, or anything being hidden. So you have these dual sessions kind of throughout the entire practice of this model, not just with the individual child and in the group, but also with the parent, because it opens up space for the parent to feel a lot more comfortable to be talking about this. And we firmly believe that you can't do great work with a child unless you're including this process with the parent who is the expert on their child. So being able to enhance the family communication about the trauma really comes through the practicing of the narrative, and then the saying it out loud and the being able to have this be something that the family can talk about as a unit is what really increases the exposure to trauma reminders while encouraging the utilization of the coping tools that the family has identified side feel the most helpful for them. And because we have such a strong belief in the connection to the incarcerated parent, many of these narratives are in fact shared with the parents who are incarcerated. So there is an opportunity for even a larger discussion to be had, that the child feels safe to share what this separation really does mean to them, and it brings the parent who is incarcerated into the treatment and feeling like they're a valued part of this process for their child. And, you know, again, just why we were very selective about utilizing narrative therapy, you know, is because, you know, this is the act of writing out, you know, the act of writing out about the trauma is an act against the trauma. So why we appreciate this so much is because it gives us the opportunity to really change, to offer an alternative story to what the experience might have been like for the child. So through the entire process of writing it out and utilizing the different concepts and tools that are very much a part of this particular evidence-based practice, we feel like this act gets to be an opportunity to really make meaning out of their experience that's ongoing, that we just get to be witness to as the clinicians. And how, you know, the idea of this work being a transactional partnership, you know, we really feel like the narrative work is the understanding of a shared humanity. It's a prerequisite for the helping relationship. So the therapeutic alliance and working partnership between the clinician and the client serves as a permanent intervention in itself with significant positive outcomes. So this opportunity to find these different mediums to really feel as though the individual and the family is getting to be in control of making the meaning out of their story, and having the you know, clinician just be very much just a witness to that has been very healing for everyone that's involved in treatment. So just very quickly, I want to give one example before we sort of wrap up as it relates to for implications for supervision and training. Just a quick narrative that some of our children were offering is, you know, what the therapeutic change process looks like is, you know, a real change in the experiences that the children have. So an example of this, one of our participants wrote, "Before I was a crying mess, so much was happening at once, all the different investigators, therapy, the loss of my mom, knowing that she was gone. I was scared. I feel that I'm stronger as a person. I'm doing okay and I've gotten better." So as you can see here, and these will be available to you, these are just excerpts that our children felt very comfortable to share as their own recognition of how much they've changed over the course of doing this therapeutic work. So I feel it's really important to highlight, though, that, you know, in order for this to happen, being able to have strong, you know, curriculum in our training process, supervision, and you know, work that we do even outside of the sessions is very important. So positive modeling and training for supervisors is critical. We use cross-cultural supervision. We use critical consciousness again. And we also really kind of come from a place of, you know, again, constantly bringing in practices that allow for the clinician to be aware of their role in this relationship. And it's intentional, it's ongoing, it's self-reflective. We have to really address these systems of oppression and racism. We have to be looking at sort of what are the particular anti-Black practices that are happening in the helping profession as it relates to these cycles of mass incarceration, and how are we helping, or how are we continuing some of these cycles, whether it's through biases, whether it's through our own misconception that maybe this parent who's in prison is not a good parent. Whatever that is, we have to tackle openly in order to become available to the experience of the child. It's critical that we can have these open and honest conversations. So this I've provided for all of you. This is the anti-racist supervisory framework that we really choose to operate from. It will be available to you, so I'll make sure that you can see it later. But this is for social work students or clinical students, new social workers, new social workers or new clinical practitioners, veteran practitioners, and then those who are in some, you know, teaching, whether it's, you know, you're working in social work or, you know, clinical programs, trainers and advocates. We can see here, what we've found is there's a lot of unaddressed implicit racist bias that's happened, particularly with this population as it relates to their own narrative of experiences with practitioners. And because we feel like there's not been a lot of direct experience with education around justice-involved populations, I've sort of outlined the ways that we feel like we can really combat this as practitioners. And I just want to really highlight that I think it's really important, again, that there is such a limitation existing already in our education. Less than 5% of Masters in Social Work programs offer a concentration in a justice-related field. And why I start with these numbers is, as you can see, it's a growing number of families that are impacted by mass incarceration, yet many academic, and training programs do not offer a concentration to really discuss and focus on criminal justice coursework. So what we feel very strongly is that if they don't include this historical context of contemporary issues, that their practice, students that are entering the field without adequate knowledge of historically racial, social, and psychological economic factors have propelled mass incarceration in the United States. This is a colleague of mine who teaches at NYU in Columbia. He really, we've done a lot of work and research around the fact that without this understanding, doing strong and combative work against these systems is going to be very, very challenging. So I'm just going to close very quickly with how, as clinicians, we can also become, part of our practice here at my agency is utilizing social work practice or clinical practice, or, our psychiatrists, our masters in mental health counseling students have become very involved in policy practice because we've recognized that 75% of people released will return to prison within 3 years because they lack the necessary support to make a successful transition from prison back into their community. And what this means is that there are not enough supportive systems in place that really recognize and honor what all the factors are that are facing parents that are, returning home from prison. There's a lot of, policies that are in place that really do, whether it's housing, whether it's employment, whether it's education, that become a barrier and an obstacle for somebody to be able to propel themselves forward. So people think that recidivism has a lot to do with repeating particular crimes, and that's not true. There's such a miseducation around what really, I'm happy to provide this information more at a later time, but what recidivism rates often have to do with is missing court dates, not being able to pay particular fees, and all of this is really wrapped up in the lack of services and knowledge that we need to, as clinical practitioners, have an awareness of when really trying to work with the family as a whole. And again, just as clinicians, it's important that we note that more than half of children and adults who were incarcerated had a mental health diagnosis. 1.2 million incarcerated people have been diagnosed with a mental health condition. One of the things that has been said throughout the last several decades is jails are becoming, essentially replacements for hospitals. So many individuals who are suffering with some level of a mental illness that's untreated and not getting the resources they need are often some of the individuals who are getting arrested. And as a result of that, there's not proper treatment that's been happening at all angles by the community, by society. And so many people are getting incarcerated that in fact need some level of intervention. Our hope for, in closing, I just want to share that our hope for what we plan to do as an agency and opening more sites and taking this training model, out into other spaces is being able to expand the existing research we do have. We've been able to have about a decade's worth of narrative work coming from the children and adolescents who have so generously shared their experience to help us as practitioners to really reframe a lot of the work that we go into when having this conception of what the implications may or may not be for somebody who is experiencing a parent lost to incarceration. We are very committed to infusing mass incarceration-specific content into all clinical curriculum and supervising practices, and we're hopeful that these different areas will be able to be addressed through our training process, which is really looking at complex trauma, child development as it relates to parental incarceration, providing agencies and practitioners with culturally responsive trauma assessments that we've utilized that have become very effective here in the last 10 years. And really a huge commitment on a policy level to dismantling anti-Black practices in clinical practice and in education, and continuing our work with criminal justice research. So with that, I am more than happy to take the last remaining minutes to be able to answer any questions you might have.
Sure, thank you so much, Anne. I think that was a wonderful presentation, and we have a couple questions and comments that have come in throughout the webinar. I just want to remind everybody to please use the chat box. It's on the bottom right, and just make sure to send to all panelists in the drop down for any questions that you have. And so I just wanted to highlight, Anna, that a few folks had submitted their comments saying that they have worked with children whose parents are incarcerated, or some that
Oh,
haven't
great.
yet but were really interested in the topic, or
Great.
they were kind of so new to the topic they didn't really know what to ask. So I think this was like a really good grounding for many folks.
I'm happy to hear that.
Yes, so I think there was definitely a lot of interest there. We have, I think, one question, and I think this is helpful because our reach in CTAC goes across the state, and I think we even have a couple out-of-staters on as well. And some of our providers work in more rural areas or work in areas where maybe the participants, the patients that the clients that they're working with are may not be people of color. So we have one comment from somebody who has worked with children who have incarcerated parents, but they've all been Caucasian single mothers, oftentimes living in rural areas. Do you have any thoughts around implications for treatment or services? Anything that, you can say? I'm assuming a lot of this can translate. You're going to see a lot of the same sort of symptomatic issues. Is there anything you can add to that?
Yeah, what I would say, I think that it's a great question. I appreciate it. What I would say is a lot of the assessment tools and when thinking about ambiguous loss and the conspiracy of silence, I mean, that really can go across the board in terms of a great starting point. Individuals are still very children, at least, what we have found in our research, regardless of sort of demographic, have been very ashamed to talk about their parent being in prison because of the societal sort of assumption and biases as what that might mean, that who their parent is. So I think in recognizing that there is a lot of all of the tools that have just been outlined today can absolutely still be equally effective, because even if there's not the component of race that might be in existing in that particular jail or prison setting, still recognizing that the fear that many children and adolescents have about opening up and talking about where their parent is and how that's affecting them, and feeling safety in an effort to be able to share too that more often than not we have found that the child really loves his parent, and so being able to really honor and make space for it to be something where that gets to be very safely expressed and supported. And any of the other tools that I've presented today can absolutely be applied to that same concept of just really combating stigma and shame around having a parent in prison, regardless of the demographic.
Great, thank you so much. And I'm actually going to show, because we'll have, just as a reminder, the webinar recording, the slide deck, and a couple of the handouts will be posted on our ctacny.org website. And I'm just going to show you a toolkit, and I don't know if there's anything you want to say about this. I think it's easy kind of a summary handout as to your approach.
Yeah, so as you can see here, if you want to jump down to some of the, if you look at, sorry, my thing is moving a little slow. I have resources for family members and clinicians, and if you take a look, and I have countless others that we've used here, but if you jump down to those, some of those can be really exceptional books and activities and tools that can be used within the therapeutic session that speak directly to the incarceration that have been wonderful. And we've received great feedback from our clinicians that being able to do these readings in session, being able to kind of work from particular workbooks, they have been very, very helpful in bringing out the conversation very quickly about incarceration, so that the clinician and the child don't feel like they have to sort of dance around anything. It can really be brought to the forefront right away, and it can be a significant part of their work together, because I imagine it's been our experience in our research that many of the children have kept this a secret. So having these particular books that are meant to be utilized in therapy can be a very, an extremely helpful tool to just kind of bring that conversation into the session, or bring that theme into the therapeutic work depending on the child's age.
Great, thank you so much. And we'll make sure that if you can't really see that, we'll make sure that's posted on the website so you can access those resources later. And I believe there's also an article that and a row that will also be posted to give more information. We have a few questions coming in. I think one is probably on folks' minds because it's very timely due to current events. And somebody asked, can you speak to how best to help immigrant children whose parents have recently been incarcerated or detained at the borders, knowing that that is also a concern because some of those children are also here in our area? And I don't know if there's anything you wanted to say about that.
What I can tell you is a very close colleague of mine actually works in the school system, you know, with a lot of adolescents who are being directly impacted by this right now. And she actually uses her own adaptation of TFCBT, of the trauma-focused cognitive behavioral therapy. And so again, what I think can be some of the most, you know, empowering and helpful work right now is definitely being able to utilize this, again, with intentional adaptation and modification, but a particular model that allows for narrative work to happen, whether it's through writing or drawing, but being able to offer some semblance of sort of security and their own story, being able to come out at a time where everything feels incredibly, where they might feel very powerless. This has been an intervention that we have found that many of the feedback is they feel a lot more empowered in their own narrative after going through these phases of the work at a time when they feel completely powerless. So she's used this particular model with children presently who are being impacted by these separation and losses, and doing it both in individual and in group work. Group work, I want to highlight really quickly, is very, very, very powerful. It's this shared identity and this kind of shared sense of community has been very enriching for a lot of the children and adolescents to feel like they're not alone. So it might be important if you are in a setting that would offer group work to begin to do some of this narrative work also as a group to build that sense of community and strength amongst their peers.
Great, thank you, and thank you for also addressing how this group work can also be helpful. Yeah. I think we only have about time for one more question, and so there's a few questions coming in. I do encourage you. We're going to have Anna's contact information up shortly, so you can also reach out to her. And there's some folks inquiring more about your specific clinic and services there. So I encourage you to also check them out on the website. I think one question that I have that came up is, what if the parent who is incarcerated is in another state or far away, where communication may be difficult or seeing them may be difficult? You know, is there a different approach or other sort of things to consider there?
No, that's a great question. You know, we've also had children whose parents have been placed in other states, and it's very heartbreaking. And you know, one of the things that I would just make sure is just really getting a sense from that child or adolescent, you know, how they identify and define that relationship, and definitely weaving in some sense, some letter writing process, because I think that level of correspondence we have seen over the last 10 years to be very healing for the child. And I cannot even begin to express how important it is for that parent who is away to feel like there is a space that is supporting a level of communication. All of the same theories and therapeutic interventions still apply, even if they're not able to see them, because again, it just offers an opportunity to make meaning out of their circumstance and situation. But you know, again, if the child or adolescent identifies as having a positive relationship with that loved one, then opening up the therapeutic sessions or even group sessions to be inclusive of letter writing can be very, very powerful. And like I said before, the feedback we've received from a lot of the parents who are in prison in different states has been, I mean, life-changing, you know, in terms of their own appreciation and validation that their relationship does matter.
Great. Thank you so much, Anna. So I think we're going to focus on wrapping up. I do encourage you, Anna's contact information is up on the slide. Again, the slides will be posted on our website, ctacny.org. For those of you who are interested in accessing the CE, I do want to make sure you get a chance to hear this. Basically, the Silver School of Social Work at NYU manages the CE. So you'll get information and a link as to how to access this in email, probably within the next day or so. And again, this is for social workers, licensed social workers, as well as LMHTs. And you'll be able to find on the Silver School portal, you'll be able to find today's webinar. You'll have to register. There is a $15 registration fee, and you'll go through a process with them to answer a knowledge assessment and then they'll give you additional information for getting the certificate. So you'll also get the link for this information in the email, as I said, for those who are interested in getting that CE. Just one last thought, our next upcoming webinar is Understanding Adolescent Self-Injury by Dr. Janice Whitlock, Thursday, July 26th from 1 to 2 p.m. I encourage you to register for that and to join our listserv so you can hear about all the wonderful presentations that we have. Our website, again, is www.ctacny.org. There are a number of references and resources that will also be posted on the website along with today's webinar. So I just want to take a second to thank Dr. Anna Morgan-Mullane for a wonderful, thought-provoking presentation with a lot of practical information. And please feel free to complete the feedback survey that will pop up at the end of the webinar. Give us some feedback. Let us know if you're interested in this topic, hearing different aspects of this topic, as well as other clinical topics. Thank you so much and have a great day.
Thank you.